We've all had that moment when we're preparing to do an IV access and we're feeling for the patient's veins and we're not feeling them. And we're checking the antecubital region, not much there. We check the back of the hand, not much there either. Today, I'm going to share with you a case that I did with a little bit of clinical video where I accessed a vein on the back side of the forearm. It's not something I do often. Usually, I kind of stick in the AC region, but it worked really well for me. And I just wanted to share it with you. It's something good to have in your tool bag. Now, when it happens that you're not feeling a vein in your normal area, your heart rate starts to go up a little bit sometimes because you know you're going to have to be on top of your game if you're going to get that IV access. So before you go and start having the patient do calisthenics or try to, flex their muscles to pump up their veins or putting bags of warm water on the back of their hand, let me tell you about accessing a vein on the back of the forearm, which may be a better alternative for you. Now in this video, I'll be accessing a branch of the basilic vein on the posterior portion of the medial forearm. Before attempting this, we need to think about the nerves that are coursing through this area. The incidence of nerve injury from IV access in the arm is anywhere between 1 in 25,000 IV insertions to all the way up to 1 in 6,000. Now, most of them resolve within a few months, but permanent damage cases have been reported. So what nerves actually run in the posterior forearm area? We have the lateral antebrachial cutaneous nerve, the posterior antebrachial cutaneous nerve, anterior and posterior branches of the medial antebrachial cutaneous nerves. And lastly, and perhaps most significantly, we have the superficial branch of the radial nerve, which runs right through this area in the anatomical snuff box, and it runs right by the cephalic vein. More important than knowing the names of all these cutaneous nerves is knowing that there are indeed nerves that relay sensory information from the surface of the forearm, and damage to those nerves can lead to permanent pain, numbness, paresthesia, tingling, burning sensations of the patient's skin. It won't cause any motor dysfunction, most likely, but what it will cause is disruption of the patient's sensory information from that area of the skin, from that dermatome. Each one of those nerves courses pretty much in a parallel pathway to the veins that we're oftentimes trying to access, such as the cephalic vein, which is kind of out here on the radial surface, and then the basilic vein, which is here more towards the medial when we're looking at someone's arm in anatomical position. And so that means they're right there. And you say, well, are you at more risk of puncturing those nerves if you're going for an area on the posterior forearm? The answer is no, because those same nerves actually originate, they pop out of the fascia right up here in the region where we're getting our IV access or doing our blood draw or whatever we might be doing. So that means that we're already in that area, and those nerves are right next to those veins that we're trying to access. So we're really never safe. And that's borne out by the fact that a lot of injuries that happen to cutaneous nerves are actually in the AC region. So it's not like this is just a safe playground where we can just go poking needles wherever we want without any risk of causing injury. In fact, injuries happen there. And that's something that we should always be aware of. But here's the good news. When we look at Netter's drawings, that OG anatomist that did the super detailed cadaveric dissection drawings that we all studied back in school? Well, when he drew his nerves and his veins, what we see is that the nerves are almost always underneath the veins. In other words, they're deep to the veins. So that means that if we're really accurate with our blood draw and we hit the vein right on, and then we keep the needle within the lumen of the vessel and don't poke out the deep surface, the deep wall of the vein, we stay within the lumen, we'll be safe from damaging any nerves. Now, obviously, if we drive too deep and go through the back side, the back wall of the vessel, and we go deeper into the tissue and we think, oh, we still haven't hit the nerve or we still haven't hit the vessel, then yeah, you could definitely get into a nerve. Or if you miss the vessel entirely and you just keep going and going and going, thinking you're going to get flashback into your catheter, you got another thing coming. So that's why it's really important to palpate well, make sure that we know what we're feeling and that we are accurate with our needle insertions. So you might ask, what is the safest vein to access? Well, it's probably in the AC region right here, the median cubital vein. It's this little short vein that runs right over the bicipital aponeurosis. And so you say, what is that? That is a thick, fanned out band of connective tissue that comes off of the bicep and then inserts into the deep fascial tissues of the forearm muscles. And that thick band of tissue, right over the top of it, you have the median cubital vein. It's protecting the brachial artery and the median nerve, which are right underneath that aponeurosis. But that thick band of tissue is kind of a protective layer that you should hit before you get to those. But if the median cubital vein is not an option, the back of your hand is not an option, the posterior forearm is what we're here to talk about today because it may be a good option for you. All right, so let's jump into this case. We start out locating this vein, and we can see it. It's sort of bulging on the back side of the forearm here, sort of to the medial aspect in anatomical position. It's right over those extensor muscles of the forearm. You can see I'm having the patient kind of rotate. She's kind of internally rotating, or you could say pronating her forearm to allow better access, and that was very nice of her to do that. We have the tourniquet in place. We're cleaning and preparing the area with 70% isopropyl alcohol with chlorhexidine for 30 seconds, allowing it to air dry, and palpating the vein with gloves. Now you can see we're puncturing the skin, getting flashback, and so we know that we have entered the lumen of the vessel, but we don't push off the plate just yet. We go ahead and we level out from 30 degrees down to about 20 degrees. And now what we do is advance maybe 1 to 2 more millimeters into the lumen of the vessel. And now we begin to advance the catheter into the vessel. And once it is advanced all the way up to the hub, you can see I'm having to push a little harder here than I normally would. I go ahead and remove the needle. As I'm withdrawing the needle from the catheter, I'm placing my index finger over where I know the tip of that catheter is to occlude any blood flow and prevent backflow of blood out of the catheter, which can be kind of disconcerting. Withdrawing the needle out and then activating the lockback mechanism. And then my assistant hands me the IV line, and it's already been flushed, so we get all the air bubbles out, so it's just fluid. Actually, this is half normal saline with 5% dextrose here, and I'm connecting it to the catheter. With that tourniquet removed, I'm having my assistant open the roller up on the IV a little bit, and we're checking the sight glass. It should be able to go drip, 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 real fast when the roller is opened all the way up. And meanwhile, I'm checking the skin, make sure there's no swelling or extravasation of fluid into the interstitial area, and that the patient doesn't report any pain. If I missed and the catheter is inserted into the interstitial space, into the dermis, it'll start to pucker up, puff up, swell, and the patient will report pain almost immediately. I tell her, it's gonna feel cold going up your arm, but you shouldn't feel any pain. She says, no, I don't feel any pain, so it looks like we're good. So now we go ahead and prepare the tegaderm, and we place it over the top of the catheter and IV line, and that just keeps the area sterile, keeps everything in place. And then I also do a few wraps here. What I'm trying to do is get it so the IV port's diaphragm is pointing towards me, so that when I'm going to access this throughout the procedure, I'm not having to twist her arm over to get to where I need to administer medication. Now you can see I did cause a little kink here, and I don't think I noticed that right away, so I had to go back and undo that. I hope that you can add this to your tool belt and that it can be helpful to you. Thank you so much for watching, guys, and we'll see you next time here in the interdental space.